so that you're able to make those informed decisions. The only thing harder than making these decisions and having these hard conversations is not having them and then needing to make them under a crisis situation, saying we need to know right now, not knowing what your loved one's hopes, wishes, and expectations are, or not having the access to be able to speak for them and knowing what they are because the documentation hasn't been completed. The access to the healthcare providers haven't been completed. I am that guy that I'm going to give everybody homework today. The first thing I'm going to ask you to do when the program is over is on a single sheet of paper, write down what is most important to you. What is your definition of your quality of life? Being able to say, what's my purpose, my pleasure, my pride on those cold, rainy days when all you want to do is pull that blanket up over your head? What are we going to do to motivate us to be able to get out? We, when are we ever going to consider ourselves old? We're never going to consider ourselves old. It's a trick question. Americans spend billions of dollars on hair products, cover up, Botox, testosterone pills, because we're never going to consider ourselves old. When we get 1 year older, we kick that magic line down. We need to be able to plan for our loved ones. We plan to be hopefully fall in love, get married, buy a house, have children, but we don't plan for when we get old. The American Healthcare Society has made so many unbelievable breakthroughs in the recent years. The average lifespan is gone from the mid to late 70s to the 90s, but we need to ask ourselves, are we potentially trading in longevity for our quality of life? There's no universal definition of those qualities of life, that purpose or pleasure. It was Abraham Lincoln who shared that it's not the number of years of life that matter as much as the amount of life in those years. Why are we talking about all of this? Our bodies change as we grow older. Things start getting more challenging. Our heart doesn't pump as effectively. Our kidneys work harder to be able to keep up. Our eyes change. We need to have adaptive devices. Our bones, we need to take more supplements to be able to keep them sturdy and strong. We have to put lotion on our skin to be able to keep it elastic. Our hearing changes. We need to be able to come up with the things that can support us. And many of these changes that we're seeing are directly because of chronic conditions. Some of these chronic conditions and normal changes are because of slight things that we may or may not be aware of. If we have hearing problems cognitively, it's going to limit our ability to stay active, even that we're physically present for different events. We're not going to be able to actively engage. Our brain is like every other organ. If we're not able to exercise it, have it stay sharp because we're not able to participate, our brain would fatigue and also atrophy. Are there slow changes that we're starting to see over time? Our orientation changes. Our orientation's judged on three spheres: person, place, this is where I am, and time, the year, the date. It can be very different from 9 o'clock in the morning to noon to 3 o'clock in the afternoon. This can be brought on by things like we talked about: urinary tract infections, medications that have worked so well for us but aren't working because or also because of a fall. These things come true by the slowing of our thought process. What is not normal cognitive changes is the inability to be able to do those things. We need to listen to our head, our heart, our gut. If we start seeing changes in ourselves or our loved ones, we need to be able to talk to our doctors. Again, many of these things are because of chronic conditions. A chronic condition is something that oftentimes it just started. You don't have an acute change. It's something that can come up. There's no oftentimes start. The definition of a chronic condition is that it can't be cured. It can only be managed. It's being able to talk to the doctor. What's the symptoms that are presenting? Some of the most common chronic conditions are congestive heart failure, COPD, diabetes. All of those affect our mind, body, spirit, and soul. Those are our four pillars that keep us balanced and keep us strong and keep us being able to be our best. When we don't have these treated by going to the doctor, oftentimes we may not want to go to the doctor because we can be fearful of what that doctor might say. And the worst thing about this is when we have a chronic condition, our brain, with the hormone cortisol, when we're stressed out, pumps that hormone out, and it affects how our bodies are able to manage stress. It manages inflammation, um, how our bodies can have arthritis, how our muscles can tighten. We need to be able to manage that and have the remedies from our doctor or our environment working more for us, or have techniques, breathing exercises to be able to keep us calm so we can be able to go on. Why are we talking about this? Well, in the early 2000s, New Jersey had the ominous reputation for having the worst last 6 months quality of life throughout the United States and the highest frequency going to the emergency room at the last 6 months of the United States. Those are two medical records that we would not have wanted to be able to claim. As a result of that, New Jersey initiated the New Jersey Health Association for Quality and Patient Safety. It had several different components to it. The first is to be able to come up with educational materials, documents, having policies so it can help people have better quality of life, having perimeters for healthcare, for physicians, being able to have groups come out to become more informed healthcare consumers, being able to develop the document called the POLST, the Practitioner's Order for Life-Sustaining Treatment. We're going to talk more about that in a little bit. The goals of care conversation are really important to be able to spark these conversations with our loved ones. What's our understanding of some of the illnesses that we're dealing with? What are the wishes, hopes, and expectations of ourselves, of the healthcare community, of our friends, our family? Being able to become an informed healthcare consumer, having the conversation of your life, being able to know what's important, know what the diagnoses are, and being able to have a plan of care, goals of care, a mature life plan in place so that you can have your power, control, dignity, and your loved ones have that peace of mind to know what's going on. There's still so much more work that needs to be done, despite the New Jersey Healthcare Association for Quality Patient Safety being born. In New Jersey, in between 20 and 25% of the US population and representing New Jersey actually have these documents in place: a living will, a health proxy, a power of attorney. We're going to talk a little bit more about that. Many people still think that there's challenges out there and our doctors know everything about us. You know, Dr. Oz was back in the day, that person, when he had his show, I felt like he knew everybody personal and able to make these decisions. He knew the questions and the answers before the people were able to say that. In the American healthcare system, the primary care doctor is the cornerstone of everything because there's so many different types of doctors. There's cardiologists, pulmonologists, endocrinologists. You need to make sure that that doctor has all of the information, all of the diagnoses, all of your medications, so that there can be one voice to be able to speak on your behalf. Being able to have somebody go to your doctor's appointments. It doesn't make any difference if you're alert and oriented times three, person, place, time. It has very little to do with a person's cognition, what school they went to, level of education, their intelligence. If conversations start to get hard, it's all about where are we on our emotional threshold of our emotional barometer. Being able to have someone that knows what's important to me, take notes, ask questions. What are the three most important questions that I hope to be able to be answered when I go in? And what are the three most important takeaways? Being able to ask our doctor so that they know we are more than just that person sitting in front of them at the time on the examining table. Does that doctor know that I'm taking care of my sick wife? That finances are starting to get tough. Sometimes I need to be able to make the decision, am I going to get my medication or am I going to need to skip a couple meals? Making sure that doctor understands your values, wishes, and expectations, that we are able and we're comfortable to come up and honor those treatment plans. Asking those questions. Why does that doctor think that I have this diagnosis? Has he helped somebody in my situation before, my age, with other diagnoses? Should I have a second opinion? Being able to make these decisions. If we want to go and get a second opinion, that is more than fine. You want to make sure that you reach out to your health insurance that it's going to be covered. Don't go to another doctor inside that same practice. When you go to a doctor's office, you're going to see the list of all the different doctors on the outside. That is very much a pecking order. If we're seeing the doctor in the middle of the bunch and we're going to see another doctor that might be lower than them, the likelihood of that doctor being lower in that order is going to be pretty limited to say, I can't and I don't believe in that doctor's diagnosis, who is my superior. Step outside. Make sure that we have information from our medical portal, the EMR, the electronic medical records. Ask to be able to have your code. Print information out. What are the tests? What are the laboratory examples so that you don't need to go and have all of those things be taken out again? Also, what's so important is that doctor's definition of a successful treatment consistent with your definition of a successful treatment? What are the recommendations that that doctor's saying? Do you feel in your heart of hearts you're able to do that? How is that going to change if I'm not here at my strongest level, but I'm at my lowest level? We need to have our doctors be aware of that scale so that everybody's not saying, I'm fine. Fine is I'm stiff and I'm still able to walk out the door to get to my physical therapy. Fine is also I'm on the floor, I can't get up, but I'm still able to move my legs. Don't use the word fine anymore. Give as many clear examples to your doctor and your optimal, possible, and problematic approach to your functionality, to your cognition, so they're able to see through the same set of lenses as we are. If those recommendations for interventions don't sound right, we have the right, and this is in all of our patients' Bill of Rights that all of us have that are given to us in that thin packet oftentimes, that the doctor's office gives that, please look that over to be able to ask informed questions. Some of the informed questions we could ask are there any alternative medications out there, non-traditional or experimental out there that I should be aware of? Ask your doctor when a new diagnosis is given, time to be able to process. This is one of the benefits of getting in front of these hard questions with your loved ones who would be with you along life's journey. Let your thoughts marinate. Being able to leave there with more information if it's a new diagnosis, I'd like to be able to learn more about it. I have yet to hear any physician say, thank goodness for WebMD. That's just made my patient's life so much easier and my job so much easier as well. Thanks. WebMD is written as if everything what we are dealing with, we have only that one diagnosis. There's a reason why doctors go to school for as long as they do. With every different chronic condition, the complexity of our full medical profile gets more complicated. That's why we want to make sure whoever we're talking to knows the full picture. 4 out of 5 doctors say, like, what's the validity of what we're reading on the internet today? I will always remember this. This was probably going back 5 years ago now, and I was looking through different feeds on my social media, and one of the captions came up, a man's beard has 5 times the volume of germs in it than a dog's mouth. I thought to myself, oh my God, my poor wife. And then I thought, oh my God, that's disgusting. And then I thought to myself, okay, Kellogg, take a minute, read the document. It was 5 pages long. The very last statement was research study paid for by Puro Inc. Does anybody know what Puro Inc. is? I won't make you guess. Puro Inc. is the parent company of Barbasol, which is the men's shaving cream. Of course, they're sponsoring that because they want people to buy their product. Shaving cream can be advertised like that. Pharmaceuticals can be advertised like that. If we take recommendations from anyone, very, very important, whether it's a company, a medication, a recommendation for an adaptive device, it's okay to ask, is there any recommendation why you're doing that? Are there any outside incentives that you think I should go here? Because all recommendations should be non-judgmental and non-biased. Ask those questions before you buy in. Once we have our thoughts and we're familiar with what our diagnoses, what our clinical pictures are, it's important to be able to come up with what our true values are. It's hard to be able to find that out. And this is me going back to the homework assignment that I asked you to do earlier. On the first sheet of that paper, you're going to write down what's most important, your quality of life, your hopes, your pleasure, your purpose, your pride. That's hard to be able to write that down in one sentence. On the opposite side of that piece of paper, write down what keeps you up at night. What don't you want to have happen? Those, when you write that down, needs to be the bookmarks for your friends, physicians, and family. You want everybody on board to optimize the likelihood of the things that we want to have happen and limit the risk of the things that we don't. It's hard to be able to find out what's most important. The one thing I do with my clients that's a very useful tool is the Go Wish game. Any item that I talk about here tonight, I am non-affiliated with. It will not benefit Chris Kellogg or Nightingale NJ. The Go Wish game has several different statements on the back of each card. I want to have human touch. I want to be free from anxiety. I want to make sure I have my financial affairs in place. I want to be able to pass at home as long as my care needs are able to be met. The Go Wish is able to be purchased for just under $25 on thegowishgame.com. It comes in Spanish as well. Being able to write these down, there's 52 cards, putting them in 3 categories. What's most important to me? What's somewhat important to me? What's not important to me at all? Being able to ask all these questions to give us that list to kind of bring our thoughts together is a first step. Take a picture of this, and it's okay to be able to change those cards as time goes on. Being able to get started on legal matters, again, advanced directives, health proxies, power of attorney, living will. Again, we want to be able to make sure if we go to an attorney, it's with a true elder law attorney. I generally tell people if you go to an attorney that can help you open a business, get divorced, and do 3 other things, that's someone that you might want to not go with because, again, there are enough nuances that will make a difference in making sure that the documentations are done correctly. Last will and guardianship. These are all documents. A health proxy is a person that would make medical decisions for you if the time ever comes that you are not able to do that any further. If I named my wife as health proxy right now, which I have, it doesn't mean that she has the ability to speak for me. This is only in place if the time comes that I'm incapacitated, I'm not aware, I'm unconscious, and I'm not able to make those decisions. Are the person that we're talking about able to work well with the other people in my circle of influence? Are they able to make those hard decisions if I know that there comes a time I'm not going to want to have extraordinary means done, keeping me alive through machines? Is she able or he able to say this isn't what he wants? Don't name someone that they're not able to do that and have these hard conversations with them before you are naming them to a legal document. A power of attorney is different from a health proxy. A health proxy has to do with medical. A power of attorney has to do with financial, being able to move finances on your behalf, pay bills on your behalf, talk about different services to be able to make sure that your care needs are able to be met and being able to be reimbursed for them on your behalf if the time comes that you're not able to do those things. A living will has to do with a list of instructions of things that I want to have happen and things that I don't want to have happen. Under certain circumstances, we're going to hear that a lot. I may not want to have compressions, CPR, to get my heart started again if the time comes that it stops. I may not want to have a ventilator put in to breathe for me if that time ever comes. Artificial means like a feeding tube. Again, all of that is under certain circumstances. Oftentimes, a health proxy is named in there. You want to have oftentimes more than just one, but an alternative, maybe 3 people. If there was ever a time in order, this is the first person you speak to, this is the second person, this is the third person you speak to. The last will is talking about things that you want to leave to people that are important to you, having them be documented in that form, making sure that All of this is clearly written down. The people know what assets you have. Are there little labels on certain things that you want them to have? Having that all be clearly being documented. All of these documents are in place to try to limit the risk of needing to have a guardianship. A guardian is someone that has been deemed incapacitated by two different doctors that does not have anyone to be able to speak for them. They have been deemed through the court system, and oftentimes a social worker through a county is appointed to them unless it's through an organization like volunteer guardianship one-on-one, where there are people volunteer, there's background checks, several different education panels, monthly education panels, and the board members is a not-for-profit program are comprised of social workers, nurses, attorneys, wealth managers, and police officers. Those people act as a bullpen for those guardians to be able so they can be their best to serve their wards that they're named for. In the state of New Jersey, you don't need to go to an attorney to be able to have these documents. You can go and grab information about the 5 wishes. It was written by a gentleman named Jim Tulmy. This is him and myself a couple years ago with the American Bar Association Commission of Law for Aging. It's written in simple, everyday language. It talks about people's personal hopes, emotional, spiritual needs. There's a section that names the health proxy, being able to do that. It has people be able to check off the things that they don't want to have happen. Circle the things that they do want to have happen, things that are acceptable to me in the case that I ever become ill and I'm not able to make decisions. I instruct healthcare to be able to do this. It needs to be witnessed by 2 different people, or it needs to be done and signed by a notary. All of these things, you would need to be able to sign this as you appoint people. Another document that is acceptable is the 4-step I care plan. These are things that all of these documents are available online or they were shared earlier. This was a document that was generated by Dr. David Burrell. It helps people know what is their diagnosis. What is their prognosis? What does that mean with this new diagnosis? What are my own goals? I want to focus on my life, not this disease. Being able to talk about what palliative care is. What comfort measures am I talking about? Palliative care, being able to continue to go to my specialist, my primary doctor, and seek intervention. Is there a time that we need to talk about hospice or comfort care, that making sure that my care needs are going to be able to be managed now and also for the future, having things be spelled out so everybody understands what is said, what it means, how does that apply to me now, and also in the future. Because if 911 is called, there's not that much time to be able to have non-medical interventions. Healthcare is educated and trained to be able to cure, not necessarily be comforted. What are some of the biggest differences? And we're going to talk about the POLST. The living will says, under certain circumstances, I may not want to have certain things done. The POLST is different because it's not written by an attorney. It's completed by you, your health proxy for you, if you've already been named, and also be completed by your doctor or nurse practitioner. The documents are here so that you're able to have the documents be filled out. What's most important to you? It's almost like a prescription. These are the things that I want right now. It's able to be followed and honored no matter where you go, as long as you have this. It's not just a green color because that's my favorite color. People in healthcare are trained to look out for this. So it doesn't blend in the stack of other papers. So in case of emergency, people go for that so that people's wishes are able to be honored in a very meaningful time. Sometimes, starting in 1997, there was a do not resuscitate order, an out of hospital order, that if a new diagnosis came on and somebody needed to leave the hospital, they're able to go. And it says, do not resuscitate on the top. That form is not wrong, but it is a little bit archaic because if you were to go to a rehab or a nursing home, you're going to need to have all of the same conversations again with another doctor for that to be reestablished. Nobody likes having these hard conversations over and over again. Once a pulsed form is documented, it doesn't need to be reconfirmed unless you so choose and want to be able to do that. There's limitations with the no CPR or the do not resuscitate form. There's no instructions about intubation. People can have compressions, but it doesn't talk about the tube going down. It doesn't talk about people's feeding tube wishes. It has lots of limitation, but the pulsed really covers everything. Who should have a pulsed? Anyone that has strong feelings about if something catastrophic happening to them and you don't want certain things done, or if you do want certain things done, you want to have it documented very clearly. Many people say, Chris, why are we talking about a pulse? I wouldn't be talking to you right now if I didn't have a pulse. No, I'm not talking about a pulse in our arm. I'm talking about the practitioner's order for life-sustaining treatment. They think because that's documented, that's the end of the conversation. In healthcare, you need to have your doctor. It's like football. He's the quarterback or she's the quarterback throwing that ball. That ball is that prescription. For healthcare instructions, it's the pulsed. I hear, Chris, I'm not looking to go anywhere, but if the good Lord calls that if my heart stopped beating or if my lungs stopped breathing, leave me alone. I want to be kept comfortable and pass away naturally without any extraordinary means. If that is your thought process, it's important to reach out to your primary doctor and say, I would like to have a conversation about the pulsed and how does that pertain to my overall plan of care. Don't plan to have this conversation at your yearly physical. Does anybody want to take a guess how many minutes we get to spend in front of our primary doctor or any of our doctors in the state of New Jersey on average? I know I'm having people say these questions out loud, but in the state of New Jersey, 7 minutes face to face. This conversation warrants more than 7 minutes. I think it's important we can go online to be able to get copies of this, and we'll talk a little bit more about that there, but being able to look at the different sections that we need to be able to consider. Section A talks about goals of care. That happens to be the homework assignment that I gave you. What is most important to me? I want to be out of pain. I want to be kept comfortable. I prefer to be able to stay home as long as my care needs are able to be met and be able to have meaningful conversations with my loved ones. That is what I hear regularly. There is no rubber stamp to that. People can also say, I want to be able to be kept alive as long as possible. But there's no right or wrong answers, but it is important that you share this with your loved ones and demystify your hopes, wishes, and expectations so that they can support you. Section B, all of these different specifiers, talks about right now without a pulse, everybody is a full code. Right now, everything, the kitchen sink would be thrown at us to try to get things started. Compressions would be done. Ventilation would be done. Whatever it takes to get things started. Sometimes people think that if I'm going to have things started, I'm going to be able to bounce back and be fine. It does make a difference. Um, it does make a difference for someone at a certain age or different diagnoses to be able to bounce back, to have that quality of life to what they were before, so that people are able to make those decisions. Again, do we want full treatment? Looking about Section B. Do we want limited treatment? I'm okay having antibiotics, IV fluids. I'm okay to have positive pressure airway. We'll talk about that more in depth in a little bit. I'm okay to have symptom treatment given. I know that there may be a time that going to the doctor, going to the hospital, there's not enough things that are going to be able to bring me back. Is it time that I want to be kept comfortable? Maybe hospice, so that my care needs can be met. My loved ones are available to be able to keep me there. If I'm at home, there's something called a do not hospitalize. What sort of things can we have on board, services available to us to make sure that we're kept comfortable and pass away naturally, comfortably, without the extraordinary means? Again, we all have our invisible toolkit that we have carrying around as we're bringing more information on. This isn't the one and only stop. I'm hoping that at the end of tonight's presentation, you're able to start asking questions to yourself. What is most important to me? Do my immediate loved ones know what I want? Are they able to fill out things on my behalf if I wasn't able to? Do they have the tools? Should I get those tools, those documents in order? Are my doctors aware of my definition of a successful treatment, not just theirs? Section C talks about artificial administrated fluids. IV fluids, are they okay? Yes or no? No. Feeding tubes, am I okay with that? Yes or no? Or am I okay with having a trial for 7 days, 10 days? People tell me, for those that I serve that are end of life, Chris, we need to go get a feeding tube. I'm okay for my loved one that I know they're dying of cancer, but I'm not okay with them dying of dehydration or malnutrition. We need to be aware that we're going to need to unlearn many of the things that have served us so well for so long at the end of life time. I've been talking to you and I've talked a lot. I've taken deep breaths to be able to fill my lungs and talk further. If I had a cold, I would have to clear my throat. At end of life, we want our loved ones to be dehydrated at that time, because they will have a time that we're not able to clear our throats. We want the air passages to be open so that there's not labor. There's different medications that can be given to dry us out so that the labor doesn't need to be so hard. Medications can be given to have comfort measures be provided to meet people where they are. Again, a lot of this has to do with the unlearning at the time, and there's different organizations out there that are specifically on board through our insurances, our providers, to help us get to where we want to go for our loved ones or for ourselves that have a diagnosis that we want to make sure that our wishes are able to be honored, because we deserve being informed consumers. Section D, talking about CPR, cardiopulmonary resuscitation. Do not resuscitate. Do I not want to have things started? There are risk factors at end of life with different diagnoses to be able to get things started again. Not being able to have the oxygen the blood flow to our heart? Are we able to come back to what we were prior to this? Am I okay to have a vent? Do I not want a do not intubate? Do I not want to have a vent? Am I okay with oxygen, the little nasal cannula that wraps around our ears? Talking about non-invasive positive air pressure. There's a difference from having a vent that is intrusive and invasive that's forced down our throat versus a BiPAP machine. Oftentimes we see it on television for people that have sleep apnea. A BiPAP machine breathes oxygen in, forces oxygen in when we breathe. It's on demand. It forces that extra oxygen to help oxygenate us. A CPAP is not on demand. It's forced air at all times, but it's not invasive to try to bring our oxygen level up. Some people might say, I don't want to have a vent, but I'm okay for a trial to have a CPAP. It's all written down. This isn't a cookie cutter document. This is why it's important to write these things down and have these conversations with your doctor. What's most important? What's not important to me? Section E, who is the one that gets to fill out the form? The pulse form is able to be documented by us. We are alert and oriented. If we've already been named as a health proxy and our loved one is not able to do this on them with themselves, we are able to do this with our doctor. If we're doing this ourselves, we have the right to say, I'm giving authority to my health proxy, excuse me. I'm giving the authority to my health proxy to be able to change what I've written here under certain circumstances because they know me best if I'm not able to say that. We can also say, I love my health proxy. They don't have the right to change what I'm writing here. But this goes into making sure that who you name are able to honor your wishes. Get along with the other people who's the power of attorney, the financial people, so that everyone is able to be informed and do what's most important to you. It's not just you filling this out. Again, you need to have your doctor or a nurse practitioner fill this out with you, trying to avoid that. Again, there's not any conflicts. If you nominated one daughter as a health proxy and now you're going to nominate a son, it really behooves you. You have that right to change it. That post will supersede what you have written down in that living will, whatever's the most up-to-date document. Section F, the signatures. Again, the patient has the ability to sign. The doctors need to be able to sign. It's being dated, making sure that there's copies out there. The form is not able to be honored if you have it in the safety deposit box. It must be present at the time of the emergency. I tell anybody who I work for, there should be an emergency contact list on your refrigerator. You don't need your private business next to the grocery list, but being able to have it in an envelope, emergency medical information, your loved ones, their phone numbers, your doctors, your medications, any allergies. They should be there when 911 is called. Oftentimes, the EMS group look on the refrigerator because that's where people have these documents be posted. There's also a section in there talking about, do I want to give my body to an anatomical gift? In New Jersey, there's two different places that will accept that. First is Rutgers Robert Wood Johnson Medical Anatomy Association, and then the second one is the Mercer County Community College Funeral Services Donor Program. It's important that if you have strong feelings on donating your body, please don't wait for your loved one who you named in here to have to go ahead and do those documents. There are forms that need to be completed. Again, the two places that You can donate your body, and they have their different forms. The first is Rutgers Robert Wood Johnson Medical School Anatomical Association, and the second is the Mercer County Community College Funeral Services Donor Program. There has been several iterations of the Pulse since it's been around since 2011. Chris Christie signed it in. I know people are saying, why haven't I heard about this form? Because we're fortunate to have our doctors, but they have been trained to cure, not necessarily comfort. And that's why I want us to be able to have our voice be heard, have these conversations of our life. What's acceptable? What's not acceptable? Because time is of the essence so that we don't need to rush to have these documents in place. Why is this so important? You know, we teach our children's our values, our wishes. Um, we talk to them about our ethics, but we don't talk to our kids about what's most important to us. There was a care.com study out there that sandwich generation, people that are my age that have children and are also seeing their aging parents get a little bit older, would rather talk to their children about the birds and the bees and talk to their parents about their future care needs. 55% of those polled had no plans in engaging them. That is a failure of my generation to not give back to our elder generation and have lessons for our younger generations. There was a Genworth study that was done a few years ago that 72% of adult children feel that their parents should have a detailed conversation about their future care plans and care needs. 69% of their parents feel that they've had a detailed conversation with them. 52% of those adult children don't feel that it was a detailed conversation. But once a detailed conversation occurred, 93% of those adult children had peace of mind, and then 95% of those older adults feel like they had peace of mind by having these conversations. We have our loved ones, and we have learned from them oftentimes what is most important to us, our ethics, our values. We need to ask them. They're not going to ask us. It's up to them and us to be able to come together, bridge that gap so that we have our power, control, dignity, and peace of mind in place. And that can only happen by having that mature life plan, the optimal, the possible, the problematic approach. What is most important? What's somewhat important? What I don't want to have happen? Where am I going to get my care provided? Do I have the tools? And that's why we need to start asking open-ended questions. Not you should do it, but I'm concerned. I want to do what's best, but I don't know what's most important. Please educate me. My name is Chris. I'm a social worker and partner at Nightingale NJ. I am terribly sorry that there was a technical difficulty at the beginning, but I'd be happy to take any and all questions. Thank you.